Good evening, everyone. Welcome back to our CMEs. Are you able to hear me now?
Yes, I can hear you, Agnes.
Karibuni sana to our CME today. We are going to be looking at vitreous hemorrhage, and with us is Dr. Oscar as our moderator. He's a vitreoretinal surgeon at Kenyatta National Hospital and also part of the retinopathy of prematurity working group for Kenya, which sees patients both at KNH and other hospitals within Nairobi, and is going to be introducing our speaker for today, Dr. Ndiritu. Please feel free to put your questions in the chat box to be responded to at the end of the presentation. Thank you. Karibu, Daktari.
Thank you very much, Agnes. Indeed, it's a wonderful evening. We've just kicked off the retinal session today. And this actually feels like a breakout session from the retinal, discussing more retinal. Wonderful stuff. So today we're discussing various aspects of vitreous hemorrhage. And of course, we all handle this, whether you're a retinal or not a retinal person, you will see vitreous hemorrhage. We're lucky to have Dr. Judy Ndiritu with us today. She's a retina specialist based in Nyeri, and she traverses into Nairobi, of course. And without much ado, as we call this a breakout session from the retina, take us away.
Thank you, Dr. Nyango. Am I audible, Doc?
Yes, you are.
Yes, you are, Judy.
Thank you. So let me start screen sharing. Okay, so as Dr. Onyango said, the presentation today is on approach to vitreous hemorrhage. I might add that this was not the original topic for this presentation. The selection of this topic came up because of Dr. Kibata's complaint on the main group about a colleague who's perhaps being a bit aggressive with use of anti-VEGF in vitreous hemorrhage, and that highlighted perhaps a need for a knowledge gap to be filled. So this presentation is in response to that. So I hope the colleague is here with us and is watching. So let's get started with a definition. Before we begin, I will mention that this presentation does not have images because I presume that all of us are ophthalmologists or healthcare workers and we all know what vitreous hemorrhage looks like. So vitreous hemorrhage is the presence of blood in the space outlined by the ILM of the retina posteriorly and laterally, and by the non-pigmented epithelium of the ciliary body anterolaterally, and the lens zonules and the posterior lens capsules anteriorly in a normal eye. Now, what are the causes of vitreous hemorrhage? The pathogenesis behind vitreous hemorrhage is basically driven by four main mechanisms. One is retinal vascular disorders that cause retinal ischemia, which is the drive behind the production of vascular endothelial growth factor and other growth factors that then cause new vessels to grow. Those new vessels are fragile and they tend to bleed. The other mechanism is if there's a retinal vascular abnormality that is not associated with retinal ischemia. Number 3 will be the rupture of a normal retinal vessel caused by trauma or any other cause. And the fourth one is breakthrough bleeding. We all know that most of the cases we see of vitreous hemorrhage will fall under number 1. So, under the retinal vascular disorders that cause retinal ischemia, these comprise the majority of vitreous hemorrhage, 60% and above. Retinal ischemia drives the production of vascular endothelial growth factor, basic fibroblast growth factor, and insulin-like growth factor, among other growth factors. And these angiogenic factors cause new blood vessels, which are fragile, and they bleed easily when there's retinal traction. So examples of these are PDR, vein occlusions, Eales disease, familial exudative vitreoretinopathy, and sickle cell retinopathy. Then there's the second pathogenic mechanism, which is a retinal vascular abnormality not associated with retinal ischemia. So these abnormalities tend to have abnormal vessels, and that's why they may bleed even in the absence of ischemia. So retinal macroaneurysms that may be associated with systemic hypertension or not, a retinal angioma, congenital peripapillary arterial loops can also cause vitreous hemorrhage. These are not very common, but they do exist, and they are an important mechanism to have at the back of your mind when faced with a patient with vitreous hemorrhage who has no underlying cause for retinal ischemia. Number 3 is the rupture of a normal retinal vessel, which occurs when the vitreous pulls, the posterior cortical vitreous pulls on the retinal vessels. It may be spontaneous, as in PVD, or it may be caused by trauma. It may also be seen in when there's a retinal break or in retinoschisis. Rare causes are tarsons and valsalva retinopathy, but it's important to just keep them in mind. And hematological disorders can also cause bleeding from normal retinal vessels. And it's also important to know that these hematological disorders don't often cause vitreous hemorrhage. They are more likely to cause vein occlusions rather than vitreous hemorrhage. Then the fourth pathogenic mechanism is breakthrough bleeding, which can occur when there's subretinal hemorrhage and then the blood tracks through the retina without the presence of a retinal break. So anything that can cause subretinal hemorrhage can result in breakthrough bleeding. Examples are choroidal neovascular membranes, which occur in ARMD, and other rare causes like tumors or IPCV. Basically, causes of subretinal hemorrhage can lead to breakthrough bleeding, which can then manifest as a vitreous hemorrhage. So what's the fate of vitreous hemorrhage? We know that hemorrhage anywhere in the body will undergo catabolism, but in the vitreous, there are some unique features that affect this process, and some of them are that clots tend to form rapidly, fibrin lysis tends to take a long time. There's extracellular lysis of the red blood cells and persistence of intact red blood cells. And lastly, the lack of an early polymorphonuclear response. So spontaneous clearance of blood from the vitreous can happen. It does happen, and happens much more in diseases where you don't have recurrent bleeding. So like where you don't have new vessels, perhaps it's blood tracking from under the retina or the rupture of an abnormal vascular anomaly like a macroaneurysm. So if there's no recurrent bleeding, then the vitreous is able to clear the blood. So non-resolving vitreous hemorrhages therefore tend to happen in cases where there's continued bleeding. Another reason that the vitreous hemorrhage may clear quickly, it happens in syneresis of the vitreous gel, like in high myopes who have early syneresis, and in elderly patients who tend also to have vitreous syneresis, and in aphakic patients. However, it does not clear quickly in diabetic patients. So it's important to just keep that in mind. It tends to clear more slowly in patients with diabetic retinopathy, both because of the nature of the disease and because of rebleeds from the new vessels. So complications that can occur due to non-clearing vitreous hemorrhage include hemosiderosis bulbi, retinal damage, hypovascular proliferation, and glaucoma. And there's a feature that one might see in patients who've had long-standing vitreous hemorrhage called an oca membrane. It's yellowish. It's a yellowish membrane like vitreous opacity that is composed of accumulated red cell debris mixed with vitreous collagen. So when you're evaluating a patient with vitreous hemorrhage, you need to keep at the back of your mind these 4 pathogenic mechanisms, take a good history, and examine the patient thoroughly, the eye with the hemorrhage as well as the other eye, trying to look for which one of these pathogenic mechanisms may be involved. So age is a useful factor to look at in newborn babies. Sometimes it can happen in spontaneous vaginal delivery because of the trauma of the process, and that will tend to clear up by itself. Shaken baby syndrome in cases of abuse, and ROP because of retinal ischemia and the ischemic drive. So in young children, you want to think of retinoschisis, trauma, you want to think of tumors, you want to think of hematologic conditions. So this is not by any means an exclusive list, just some of the things to think about in each age bracket. In young adults, especially males, eels comes forward as a common cause of vitreous hemorrhage secondary to vasculitis. So they have a vasculitis, the retina becomes ischemic, new vessels grow, and you get a vitreous hemorrhage. So in a young man presenting with vitreous hemorrhage, no history of trauma, you want to look very, very thoroughly at the other eye, because that may be your only clue as to the vasculitic process that may have caused the vitreous hemorrhage. It's also important to know that TB vasculitis, it's not just eels, TB vasculitis is actually a differential of eels. So it's important to keep that in mind. So trauma, leukemia and coagulopathy, valsalva retinopathy, and retinal breaks with or without RD can also cause vitreous hemorrhage when they involve a retinal vessel. So in middle-aged persons, you want to think of proliferative retinopathies, either vein occlusions or diabetes. You want to think of retinal tears, probably induced by a PVD. You want to think of tumors, you want to think of idiopathic polypoidal choroidal vasculopathy, and you want to think of systemic anticoagulants. Of course, trauma is there at the back of your mind and all the other possible causes of vitreous hemorrhage. In elderly patients, breakthrough bleeding can be caused by CNVMs causing subretinal hemorrhage and the blood tracking through the retina. Again, you want to think of proliferative retinopathy, vein occlusions, and diabetes. A PVD, again, pulling on a retinal vessel can cause vitreous hemorrhage, systemic anticoagulants, and all the other causes that we discussed. So when you come to the ocular examination, you want to take a best corrected visual acuity as your baseline. You want to look at if there's any iris or angle neovascularization, which may suggest to you as the strong possibility of retinal ischemia. You want to look for KPs and cells in the anterior chamber, because in patients with pars planitis, you can have new vessels on the snowbanks, and those can bleed and cause vitreous hemorrhage. You also want to rule out an RAPD, because this suggests to you that there's either an RD, a very large macular lesion, an ischemic retinal vein occlusion, or significant optic nerve disease. And this is important because then you want to have it to be aware of this factor when you're prognosticating whatever intervention you want to give. So you also want to make sure you check your IOPs. Hypotony, suggestive of a retinal detachment associated with the vitreous hemorrhage. It may also be suggestive of trauma with a wound leak or an open globe. Raised IOPs tend to suggest neovascular glaucoma, a hemolytic glaucoma, or the possibility of a tumor. So when you're examining the fundus, you want to, when you're looking at the same eye, it's important to know that whenever you have a vitreous hemorrhage associated with acute PVD, it's associated with a 70% incidence of retinal tears, while an acute PVD without vitreous hemorrhage has a 2 to 4% incidence of retinal tears. So in a patient where you think the cause of the vitreous hemorrhage is an acute PVD, you've ruled out everything else, then you need to do a very thorough peripheral retinal exam with scleral depression to look for associated retinal tears. So in the other eye, you want to look for any features of diabetic retinopathy, vein occlusion, breaks, vasculitis, exudative vitreoretinopathy, retinoschisis. The other, if it's a dense vitreous hemorrhage, sometimes your diagnosis will come from the other eye. So once you're done with your examination, so basically you need to examine the presenting eye as well as the other eye really thoroughly. So then in an eye with dense vitreous hemorrhage, you want to do a B scan, and with the B scan with a kinetic scanning, the A scan. And the things you want to be looking at are the vitreous cavity, the vitreoretinal interface, and the retinochoroidal layer. So in the vitreous cavity, you want to be looking to see if it's like fresh dispersed hemorrhage, or there are clots, which will be hyperechoic. They will, if there are a lot of clots, they'll also settle at the bottom, and they'll be less mobile. You want to look at the vitreoretinal interface. You also want to be looking for foreign body in the event of history of trauma. Even without history of trauma, you want to actively look for a foreign body. Then the vitreoretinal interface, you want to actively look for tractional membranes, whether the patient has a history of proliferative disease or not, because tractional membranes can occur even in uveitis. You also want to look to check if the posterior cortical vitreous is still attached or detached, and the reason is because if you're going in, for example, to do vitrectomy, and a good PVD is, good for the surgery. So if the vitreous is attached or detached, then the surgeon will want to know. Then you also want to look at the retinochoroidal layer for any detachment, breaks, epiretinal membranes, subretinal hemorrhage, choroidal detachment. This may give you a guide on the cause of your vitreous hemorrhage, and it's also important because it will determine your management. So other examinations that you may do, you may want to repeat the retinal evaluation after a couple of days. You may also want to do serial ultrasonography if you're not so sure of the cause and it's not something very urgent. You want to do a systemic evaluation if you're having difficulty establishing the cause of the vitreous hemorrhage. In this event, you want to do your workup, a blood sugar, full blood count, bleeding time, clotting time, ESR, peripheral blood film, Doppler, carotid Doppler to rule out ocular ischemia, ECG, chest X-ray, echo. So all these are to look for possible causes of your vitreous hemorrhage if you can't find them with your basic examination and your B scan and your ultrasound. So the management is tailored according to the etiology of the vitreous hemorrhage and the source of the hemorrhage. And management options, the standard management options that have been there for the last 20 years are observation, laser, or vitrectomy. So let's go to the first option. So the options depend also, besides the etiology, on the patient's age, the duration of the disease, how long has the hemorrhage been there, the visual acuity, the IOPs, the amount of hemorrhage, the status of the retina, the status of the anterior segment in terms of neovascularization, because then you may need multiple procedures and you may want to let the glaucoma specialists go in first before you go to the posterior segment. The adequacy of laser, if the laser was done before the onset of vitreous hemorrhage, the lens status, and the presence or absence of a PVD. So management by observation tends to be initiated where there's a fresh vitreous hemorrhage, There's no retinal disease that is likely to progress while you're observing, like a retinal detachment or diabetic retinopathy. So you're fairly certain of your diagnosis. Perhaps it's breakthrough bleeding from a CNVM, or there's adequate laser in a diabetic with no membranes. So then perhaps you can observe. However, you must be certain that the retina is attached on ultrasound. If it's a mild to moderate hemorrhage, you can probably see through. If you can't see through, you want to do an ultrasound. You want to be certain your retina is attached. You want to be certain that there's no retinal disease that will progress while you're observing. So you keep evaluating the patient every 3 to 4 weeks. And the kind of patients who will usually be managed by observation are a patient with adequate PRP, and you're sure there's no active fibrovascular proliferation going on. It's a stable eye, good laser in it, or post-vitrectomy with a rebleed, again with adequate laser. In Tarson syndrome, you might want to observe. In an acute PVD-induced vitreous hemorrhage, where again you've done an ultrasound and you're fairly certain that the retina is fine, or a vitreous hemorrhage associated with a bleeding diathesis, where you want to go and manage the primary problem first. So once you, as you're observing, once you treat the cause, like if it's a coagulopathy, then once the blood settles down, you need to go back, locate, and manage the cause of the hemorrhage once it clears completely. If it's a bleeding diathesis and the blood clears completely, then you don't need to go in. But in the event that the blood is persisting, it's not clearing, and you've established the cause, the blood has settled a bit, you can treat it, then you go in and treat it. So management by laser will be for cases of proliferative vasculopathy. So you want to start, this will be for mild to moderate vitreous hemorrhage. You want to start as soon as any part of the retina is visible. Sometimes you may not be able to do the whole retina, you do what you can see. So it will be, staged PRP. So you'll probably do it like every 3 to 4 weeks. Ask the patient to come in. As more retina becomes visible, then you keep adding the laser. You want to complete it over the next few weeks. And once it starts to clear, then you can be able to see what caused the hemorrhage, and you can be able to treat it. In patients without any signs of fibrous proliferation, then you may want to use anti-VEGF agents as an adjunct to your laser to induce regression of new vessels, and so that will reduce the rebleeding, and therefore your hemorrhage may clear faster and you can finish your laser sooner. So management by vitrectomy will be done for non-clearing vitreous hemorrhage, where you're fairly certain that the retina is in good condition, the disease will not progress. So like we said, like a well-lasered retina, you've seen this patient before, there's been a bleed, it's not clearing, you've given them 2 to 3 months, then you want to go in and clear the hemorrhage. If it's not cleared in 2 to 3 months, it's not going anywhere. Again, in advanced proliferative retinopathy, where it's not clearing and there's adequate laser. So it's just important to note that any condition where in any condition where you think the underlying pathology is likely to progress, you don't observe, you go in. So if you think there's a retinal detachment, if perhaps you think there's active bleeding that may continue, then you want to be a bit more aggressive and go in early. Only in conditions where you're fairly certain the underlying pathology will not continue, the retina is in good condition, then you can observe. Otherwise, you go in for vitrectomy. In a patient with a very dense vitreous hemorrhage, even if it's fresh, you go in for vitrectomy, you don't wait, because very dense vitreous hemorrhages tend not to clear, whatever the cause. So we come to management by anti-VEGF agents. IVB here stands for intravitreal bevacizumab. It's the most extensively anti-VEGF agent studied in the use in for clearing vitreous hemorrhage, so that's why I'm referring to it specifically. So it's important to know that anti-VEGF agents have recently come into use from about 2017. Most of the studies are from 2017. So they've recently come into use for management of vitreous hemorrhage, but only in proliferative retinopathies, where the vitreous hemorrhage is caused by new vessels driven by the retinal ischemia. So intravitreal agents, anti-VEGF agents, will only come in cases of proliferative retinopathy, either vein occlusions or proliferative diabetic retinopathy or familial exudative vitreoretinopathy, ROP conditions where there's an ischemic drive causing new vessels, because the mechanism of action is by they'll induce regression of the new vessels. So we know increased levels of VEGF play a role in the development of retinal neovascularization, as well as retinal vascular leakage related to diabetic retinopathy and DME, and the clearance of vitreous hemorrhage with an improvement in visual outcomes has been shown to be improved by intravitreal bevacizumab as well as other anti-VEGF agents. It also prevented rebleeds and diminished the need for vitrectomy. So this was just to establish that yes, anti-VEGF agents can be used in management of vitreous hemorrhage, but with caveats, very important caveats that I will go through in the subsequent slides. So first of all, in the studies that are there discussing management of vitreous hemorrhage, the management of option of using anti-VEGF agents for vitreous hemorrhage, the decision of primary treatment was made by a retina specialist. So the decision of whether to observe, of whether to do laser, or whether to do vitrectomy, or whether to use an anti-VEGF agent was made by a retina specialist after examining the patient thoroughly, establishing clearly the cause of the vitreous hemorrhage, the proliferative retinopathy, assessing the retina, both by fundoscopy or by ultrasonography. That decision is made by a retina specialist. So I think it's important to mention at this point that in the event an ophthalmologist in the periphery is thinking, sees a patient with vitreous hemorrhage, it doesn't hurt to consult. Send the patient to a retina specialist, let them examine the patient, then you can discuss. If the specialist thinks that you can give anti-VEGF, that it's safe to give anti-VEGF, then they can send the patient back to you with a protocol for giving the anti-VEGF agents and how to follow up the patient. So the reason for the primary treatment decision being made by a retina specialist is because the patient selection for anti-VEGF is critical, because the possibility of worsening existing pathology is very significant. So if the patient has any fibrovascular proliferation, the chances that that proliferation will contract and pull off the retina and the patient ends up on somebody's table with closed funnel RD is very, very significant. So that's the greatest risk that you want to avoid. Other contraindications include, besides fibrovascular proliferation, retinal detachments, any ocular infections, pregnancy, or recent cardiovascular or cerebral disorders. So it's a very useful adjunct also, in addition to PRP and to PPV, where there are no contraindications. So surgeons going in either to do PRP or to do vitrectomy will use anti-VEGF agents to reduce bleeding intra-op for vitrectomy, and also when you're doing laser to induce regression of new vessels and reduce the rebleeds so that the hemorrhage clears faster. So again, when you're using anti-VEGF as an adjunct to PRP, you want to be absolutely sure that there are no fibrovascular proliferations that may was I muted? So the best effect of anti-VEGF in vitreous hemorrhage is in fresh and complicated mild to moderate vitreous hemorrhage, especially in eyes with previous adequate PRP. Then you're very certain that your anti-VEGF will prevent any rebleeds, so the hemorrhage will clear and you'll be able to see the retina in 4 to 6 weeks. In a dense vitreous hemorrhage, whether fresh or non-resolving, it's best managed by ultrasound followed by vitrectomy with or without anti-VEGF. So in conclusion, I think it's just important to say that there are no hard and fast rules for these kinds of patients. You, even as retina surgeons, you really have to look very hard to make sure that there's nothing you might do to worsen the existing pathology. And you even consult amongst each other. So please you ask your colleagues, take a look and just see if this eye looks stable. So I think it's important to follow the principle of above all, do no harm. So I think let's be more conservative about using anti-VEGF agents in vitreous hemorrhage. There's a very good indication for anti-VEGF agents, DME. So, and that one, at least you can see the macula. So you just send the patient for a baseline OCT, do baseline best corrected visual acuity, and then you can, do the tailored treatment depending on how much the DME is, if there's any coexisting pathology. But basically, I think I would say for the ophthalmologists, please, I think just let the vitreous hemorrhages go to the retina surgeons. For the if you really have, you have a vial of anti-VEGF with 80 doses, there's lots of DME floating around. Just make sure you have your OCTs and you consult. Thank you very much. I hope I'm audible still. So back to Dr. Oscar. Thank you.
Indeed, thank you very much, Judy. That was a very enlightening discussion. Just to point out, we're not here to point a finger at anyone. We just need to know how to treat, how to diagnose and how to treat. You might not be able to refer. You might be in an area where maybe a retina specialist is not near you. But we keep getting these pictures. Nowadays, the phone is there. It's very easy to do phone-based fundoscopies. And you can always consult. People are a phone call away. People are internet away. I mean, there's no excuse. I mean, anti-VEGFs are there. They're here to stay. And definitely, we shall all use them, irrespective of being a retina person or not. But whenever you're not sure, please consult us. Please consult us. We do not want to end up in legal problems. Now, I've seen other members of the Retinal Society of Kenya coming in, Kibata, Shafiq, and all. Maybe, I don't see any questions in the chat so far. It's about muting microphones. Any other comment? I could start with, I saw Kareko much earlier. Any comment, Kareko? Anything you need to add? Okay, any Vitreous Society of Kenya member? We're many of us. I think we're 13. Silence. I guess, Judy, your talk was so clear, there's nothing more to add. Maybe I could ask a question as people are putting the ideas together. This, the role of the dobacelate, I think it was calcium dobacelate in diabetic retinopathy to help with bleeding. Have you seen that in any literature? Have you seen any use where you've been exposed of calcium dobacelate in bleeding eyes in diabetic retinopathy?
You're addressing yourself to me or to VRSK?
Judy.
Okay, I haven't come across it. I'll probably go look for it now that you've mentioned it. Yeah, I haven't come across it.
Yeah, it's a medication used for piles, hemorrhoids and all. And there was a time it was being peddled a lot by a company. I think it was a generic. And they were really trying to push it so that it helps with clearance of vitreous hemorrhages by stabilizing permeability of the capillaries.
I think the only time
Okay. I'm seeing a comment by Shafiq. We cannot have a blanket statement regarding sudden onset vitreous hemorrhage patients in obvious cause. In fact, one must go in immediately. Okay, the general approach to vitreous hemorrhage cannot be a blanket statement. Basically, that's what Shafiq is saying. We individualize patients. There are patients you'll go in to do vitrectomy within a month. There are those who can give it 8 weeks. There are those who can give it 3 months. So it's individualized treatment, and not everybody is for vitrectomy, as you rightly pointed out. I'm seeing Jafeji has pointed out something again. I wish you would talk. Lots of time they have a break in the eye. Yeah. Okay, Judy. Trying to say, Shafiq is really pumping, is sending in sentence after sentence after sentence. I wish he would talk. Shafiq, the microphone maybe problems or?
Hi, Oscar. How are you?
Hi. Proceed.
And Ndiritu, thank you for a nice talk. Very, very informative. What I'm trying to say here is there are certain cases where somebody turns up to your clinic, he's a little bit of a myope at times or not, but he's had a sudden onset vitreous hemorrhage. The other eye is absolutely clear. He's not diabetic, he's not hypertensive, he has no other coagulopathies or anything, and you cannot see the retina well. In such cases, if you cannot see the retina well, go in and clean that vitreous hemorrhage. Chances are you'll find a break somewhere. Yeah. Very few times it's just an attrition of a blood vessel, yes, but most of the time there's going to be a break somewhere. You leave it, come back after a month, they'll come back with a detachment. So in my experience, you go in for such cases.
Great, thanks a lot, Shafiq. Judy, any comment on that?
Yes, I agree. I think in my presentation I said if there's a vitreous hemorrhage where you can't see the retina, and you can't find the cause, then that's, you don't know what's going on. So yeah, so dense vitreous hemorrhage, you're not you go in.
Yeah, true. I've also seen a comment by Dr. Kahaki. If it's an only eye, you'd want to consider going in pretty early. And we do see these patients from even across the border, Uganda, Tanzania, etc., coming to join us. Now, so the indications basically are neovascularization without traction, and I know there are studies that have talked about PDR, use of anti-VEGF in PDR. Follow-up is important. If you go that route without doing the PRP route, going for anti-VEGFs purely in cases of proliferation, then you must follow up these patients very closely. Because these are multiple injections they're looking at, and I'm yet to see any patients who wants to be injected, and laser is 1 or 2 sessions and they're done. And as rightly said, vitreous hemorrhage, for example, if you can see the superior retina, as we teach our residents, then you laser the superior, come back in a week or 2, laser the posterior, the inferior, as it keeps going on, and it gravitates, it goes downward, and then you end up with having saved the patient a surgery. I've actually seen that also in Kenyatta. There are a couple of comments. Let me see here. Neovascular glaucoma is an ocular emergency. This is from Dr. Sheila Marco. Sometimes the patients are sent from areas without a B-scan. They mostly need anti-VEGF before glaucoma drainage surgery. Any comments on this? Judy?
I think that's usually my experience with neovascular glaucoma patients who also have a dense vitreous hemorrhage. That's a really dicey situation, because if you do your B scan and there are membranes in the other eye, then you may not want to inject. During my fellowship, I would see those procedures done as combined procedures. So glaucoma would go in, they would do their sort of tunnel for their drainage device. Without putting the drainage device in, they would just prepare the eye. The vitreoretinal surgeons would go in, clear the vitreous hemorrhage, then the drainage device would be inserted. I haven't seen combined procedures locally, so you probably have more experience with that. So perhaps you can advise whether with a dense vitreous hemorrhage and neovascular glaucoma, does glaucoma go in fast or does retina go in fast?
The cases I've had are not many, but I've had cases where I've injected anti-VEGF, then intravitreal, actually even intracameral, and then gone in 3 to 4 days after, and the surgery went well. And considering that if you don't give the anti-VEGF, remember this neovascularization is right around the pars plana area, etc. I had a case once, a Somali lady who just bled after the first spot and we could not proceed with the surgery completely. I've now forgotten, that was just disastrous. Let me ask, Shafiq, any comment on that?
Thank you, Oscar. To a good extent, I agree with Sheila that, I mean, most of the time, what Sheila is referring to is neovascular glaucoma in diabetics, or they've had vein occlusion and they've developed the neovascular glaucoma. And most of the time, what you'll have to do for them is first give the anti-VEGF injection, put in your valve, stabilize the IOPs, and then go in and clear your vitreous hemorrhage if it's there. Or, of course, what Ndiritu has referred to, you can easily combine the two also. Either ways, depends on the availability, on how you want to take it forward.
Great, good stuff, good stuff. Dr. Kibata was in the house, is very quiet today. I believe this session is dedicated to what he has seen. I think I've seen a few complications of anti-VEGF being given unnecessarily. I believe CTI has seen quite a number. Any comment from the CTI perspective? Gashago, Kibata.
Hi, Oscar and team. Yeah, I think Judy did a good job. I would just say, especially in a vitreous hemorrhage where you don't know what's going on behind, treat anti-VEGFs like the enemy. It's not your friend. There are patients who we have lasered, we have followed up over 1 or 2 years. We know how the retina looks. Absolutely, they start dialysis, then they get a vitreous hemorrhage. But because we know how that retina is, even though we can't see, we'll still give anti-avastin because we know how the retina is. But in a fresh vitreous hemorrhage, it's the first time you're seeing the patient. If you can't see that retina, please don't give anti-VEGF. Refer. You can make a bad situation impossible. And that's why I posted what I posted, because we are seeing this more and more. And I believe people are not malicious. People are trying to help the patient, but this is one situation where you're not helping and you'd rather refer. I think the other one I would like to raise is the one of Sheila, because we see a lot of people who come with acute rubiosis and very quickly develop very high pressures. And then there's this big back and forth. Oh, what do you do? Send to who? Send to who? If you see rubiosis and the fundus is clear and there's no membranes, definitely give Avastin, and two things will happen. If the angle isn't closed, the pressure will come down, and you've solved the problem. But many times the rubiosis will go, but you've got an angle closure. And so an angle closure, don't bother doing trabs. An angle closure from rubiosis is a valve. I've never seen trab to work, which is sad for peripheral, because then you don't have a choice. You really just have to just send and get a valve. The problem, and I would like to challenge Kiage and Marco, we have to make valves cheap and available to everybody. Not everybody can go to Aga Khan, not everybody can get to Kisii, and yet in those situations only a valve works. So the rest of the glaucoma team, let's find a solution for these guys. Thanks.
Thank you very much, Kibata. Changamoto to these guys. I was just going to add the way we have the ROP side, because we're seeing more and more vitreous hemorrhage also in ROP. We've managed pretty well with anti-VEGF because we did B-scan. Actually, we just followed up on B-scans. And after Avastin, I think we gave 2 Avastins over a period of probably 8 weeks or 9 weeks or so. And the hemorrhage cleared, and I believe that's one of the babies who was scheduled for laser was done laser probably a week or 2 ago, I believe. And as long as you're following up anybody you're injecting, be it a baby, be it an adult, I think you'll be on the safe side. Yeah. Any other comment? I've not heard Gashago today talking. Is he on the forum? Hatim was seen earlier, Kareko was seen earlier. I want to make this a VRSK affair. Remember, this is a breakout session from the Retina Congress that's ongoing.
Oscar, I'd like Dr. Kibata to comment, and Sheila, if she's also here. So in a patient with neovascular glaucoma, high pressures, dense vitreous hemorrhage, you do a scan, a B scan. In the event there are membranes, so who goes first, glaucoma or retina? So there are membranes and there's neovascular glaucoma, which is often the case. By the time you get rubiosis, there's some pretty aggressive retinopathy back there. So dense vitreous hemorrhage, membranes, and you have your neovascular glaucoma. So how it's ideal to do a combined procedure, but in the event you can't do a combined procedure, perhaps Dr. Kibata and or Dr. Marco can comment.
Sheila, Marco, let's hear you.
Oscar.
Yes, Kibata, go ahead.
Let me talk. I want to say very clearly, you're damned if you do, and you're damned if you don't. Either way, you're going to be in trouble. And sometimes we think there is a success. There is no success in that case. You're in trouble. And just agree and so deal with what gives the patient the highest amount of trouble, and that is pain, which is from the rubiosis. And the pain is not just because of high pressures. New vessels on the iris cause pain, and I have found this to be true. So do a paracentesis, give you Avastin. That will take care of your rubiosis, and then you can send to Sheila for a very quick valve, bring down the pressures, and then now deal with the problems behind. Now that means you really have to do those things like within a month. But many times that's not, it's not practical. So if you fear membranes, patient doesn't feel pain from membranes. Patient feels pain from the rubiosis and the high pressures. So you deal with that, and the patient is happy. They think you know what you're doing. They will stay with you. Then now you can deal with the posterior problems. And these are things I see every day. Pain is what brings the patient to you. So deal with the pain, then sort out posterior uco if it is solvable, because many times it's not.
There's a comment by Dr. Godi Nyaga that Diamox also works. Is that Sheila wanted to say something, or who was talking?
Thank you, Dr. Kibata, Dr. Oscar, Dr. Ndiritu. I agree with all of you, Dr. Shafiq. Another thing that is your biggest enemy is high pressures, because basically speaking, if I'm having pressures of 50 for 5 days, you can get optic atrophy, glaucomatous optic atrophy. So the longer the patient stays with very high pressures, the more likely their optic nerve is going to die off from the ischemic, from just having low blood going to it from some form of ischemia from the pressure. So this is dangerous, because if you delay and keep on doing interventions that are not going to adequately lower the pressures, unfortunately, by the time the patient comes to see me and they are already PL or NPL, and it's very sad to tell the patients that, you know, even if we lower the pressures using the valve, it's unlikely this NPL with an amaurotic pupil it's unlikely this eye will see. That being said, I agree with Dr. Kibata. You know, sometimes you cannot really tell what's going on at the back, but it's difficult to put in an armored valve when there's rubiosis on the iris, because the rubiosis is also the angle, and you put in that armored valve and you're going to get a hythema that you're not going to be able to control, and most likely you're going to even lose that eye. So an intracameral, an AC tap with intracameral Avastin, if you're not sure, that will work, because that clears up the rubiosis. Sometimes it lowers the pressure because maybe the angle is not completely shut, but if it's completely zipped up, at least when the rubiosis regresses and the vessels at the angle regress, then when any glaucoma surgeon puts in the tube, At least this lowers the pressure, and then now you can safely send the patient back for any other intervention. Remember, when these patients come in neovascular glaucoma, their pressures are 60s, 70s, 80s. So even going in and doing a vitrectomy with such high pressures is very high risk of suprachoroidal hemorrhage and all sorts of other complications that you don't want on the table. So it's a very tricky situation, but when in doubt, at least intracamerally may be safer than giving the Avastin or the anti-VEGF in the intravitreal anti-VEGF injection. If they're not sure, just give it intracamerally. Let somebody put in a glaucoma drainage device, and then we'll send it back and you continue with the posterior segment treatment. Trabs don't work, but they don't. They fail, I think, even within a week or even within a couple of days. So it's up to you to just send the patient very fast for intervention to whichever glaucoma specialist nearest to you. Thank you.
Oh, thanks a lot, Sheila. We're not by any chance saying every neovascular glaucoma you're padding the eye and referring. You manage, you've been taught you can manage some of these things, consult, I believe, and you'll have, at least have something to do. As Godi has just mentioned over there, something about diamoxirol as you buy time. A lot of our patients will not be able to travel easily across towns, for example. And you have to, I mean, the patient is there with you, you have to do something for them. Okay. I'm trying to say, I don't see any questions here. Judy, any take-home message, a final one? We're not telling people to pad and refer vitreous hemorrhage by any chance, are we?
Oscar.
Yes, Shafiq.
Can I make a comment?
Please do.
Thank you. Regarding neovascular glaucoma, there is something that needs to be differentiated. There are two types of cases which we are mixing here. There is diabetic retinopathy related vitreous hemorrhage, and then you get the neovascular glaucoma component. Then there are eyes which have ocular ischemic syndrome, and they get neovascular glaucoma. And if you look at the retinas, lots of times they will look pristine with minimal, sometimes vitreous hemorrhage. In ocular ischemic syndrome, the whole eye is ischemic. And the reason why you want to differentiate between the two is the way you will manage them is also a little bit different. Now let's go to the diabetic retinopathy part, where you'll develop a vitreous hemorrhage. It has stayed there for some time, and then with time they develop neovascularization of the iris and the glaucoma. In that one, if you give an anti-VEGF and go in, you will have controlled the intraocular pressures much better. You will be able to go in and do your vitrectomy, sort that patient out, do your good laser, and the outcome will be very different. You might actually end up saving the eye much more easily. Then there are ocular ischemic syndrome, where even with the high pressure, sometimes when you are able to give the diamox or anything, you look inside, you'll find that the retina looks by and large pristine. You're not seeing any much membranes in that eye. And that one, first you'll have to do your anti-VEGF, and then you'll have to do your valve. Whether you do the laser at the back or not, sometimes is not even important. Yeah, because most of the disease is anteriorly located in such cases. And even putting in laser on the retina, posterior laser does not seem to help much. These are people who need either an anterior retinal cryo or anterior or peripheral retinal lasers, where you are giving the laser from the equator towards the aura. Yeah. This is what I've seen with a lot of my cases. Asante.
Well, you've added an interesting angle to it, ocular ischemic syndrome. Now, the thing is, part of the workup Judy mentioned was looking for thromboembolic phenomena. I believe many of the diabetic patients, hypertensive, cholesterol, hypercholesterolemia, also are predisposed to all these thromboembolic phenomena, which can actually end up with ocular ischemic syndrome. So you can have the diabetic changes on one side, you can have ocular ischemic features on the other side. It's a matter of a good examination and I guess a high index of suspicion when you're seeing a clear retina and you're seeing signs of ischemia and NBIs and all this. Yeah, that's a very good point to remember. I'm trying to see here. Let me see. Oh, okay, that was a comment by Dr. Kibata in terms of accolades. I believe we've done close to 1 hour now. I'd like to welcome, if there's any comment, they're welcome. I'd wanted Judy to say something just to wrap all, after all the discussions we've had, just in 3 or 4 lines, just tell us something that we take home. We've said very many things, and then I'll invite Bea to talk as well.
You asked me if I'm telling people to pardon refer. So let me come out clearly, because I work in diaspora. I know what is in diaspora. In diaspora, there's a slit lamp and a 90D. That is what is in diaspora. So if a patient has proliferative, the patient is diabetic, or you suspect there's a proliferative retinopathy, that dense vitreous hemorrhage, you can't see through. For sure, you're not going to sit with that patient and observe. You don't have an ultrasound. You're not going to be doing laser. You're not going to be doing vitrectomy. So when I say pardon refer, okay, as much as it's a joke, but really and truly, that is the best management for that patient. You have a dense vitreous hemorrhage. You cannot see that retina. You don't know what's going on. You don't have an ultrasound. May I still think that the best intervention for that patient is to send them to the retina surgeon. I really just cannot imagine what one would be. Even if there's no suspicion of proliferative retinopathy, it may be trauma. You can't see the retina. In the periphery, your ultrasound is projection. So you think the retina is attached, but if there's no proliferative retinopathy, you still don't know what caused that hemorrhage. If it's a bleeding diathesis, you still don't know the status of the retina. So I still think, unless you have an ultrasound, you must find a way of establishing, what's going on back there. If you have an ultrasound, then do the ultrasound and consult. If you don't have an ultrasound, refer, then consult on what was done. That's my take. Thanks.
Thank you indeed. Thank you so much, Judy. Consult, refer, consult, refer. Okay, so we have Bea, the sponsors of this, though I know there's no dinner and drinks involved, rather sadly, but let's have Bea summarize for us the evening. I think Romeo, I saw you
Hello. Thanks, Dr. Onyango, for this opportunity. Thank you, OSK, for giving us this opportunity to sponsor the CME. Nothing much new I can add about from Bea. We still have Eylea, your anti-VEGF. You should say should be your anti-VEGF of choice. So mine is just to give thanks for Dr. Ndiritu for also taking us through this session. And just to mention that Eylea is quite available in the country, public institutions, private institutions, and we are looking forward to make our patients to gain access to this medication for your DME, for your RVO, for your wet AMD indications. So grateful for OSK to give us this opportunity, and we look forward to sponsor and gain.
Sorry, I think we lost Romeo there at the end. Okay, I think I'll hand this back to Dr. Agnes Kalu. Thank you, everybody, for a very enlightening discussion. And let us not see any more complications from anti-VEGFs used strongly in vitreous hemorrhage. Thank you.
Thank you, Dr. Oscar. Thank you, Dr. Ndiritu, Dr. Kibata, Sheila, Dr. Jafeji. This was a very enlightening and enjoyable discussion about vitreous hemorrhage. And I think we have taken something additional, or we have reminded ourselves of something towards managing vitreous hemorrhage. I would like to just remind us that the OSK 4th Annual Conference registration is ongoing. Our early bird is ongoing up to the 30th of September. Remember, the conference will be in Mombasa, Pride Inn, on 26th and 27th of November. So please go ahead, register, and let's meet and have more discussions that are enlightening, and they will add to the betterment of our patient management. Also, abstracts are, please keep on submitting them. The deadline for abstract submission will be 31st of October this year. Also, let's meet here next week for another CME topic will be shared in due course. We are going to have this month and a bit of next month CMEs before we finalize with the OSK conference for our CME chapter this year. Then I would like also to inform us that we also have the African Ophthalmology Council that is having its first annual conference. Please, you can go to their website, register, send abstracts, and let's keep learning more. Thank you, Bea, for sponsoring us this evening. And thank you, everyone, for
before you go, Agnes, can I ask something, Agnes? Regarding the Friday meeting, will it be hybrid? Will it be a hybrid kind of meeting where you have both virtual and live in session? Or it's purely everybody has to attend? I'm asking for people who have not gotten their 4th and 5th shots of COVID vaccine.
I have just been talking to our administrator, and for now, it is going to be purely a physical. We don't have a hybrid option. Maybe we will look into it and see if that is possible, but currently the plan is to have a physical conference.
Okay.
Sawa sawa. So thank you, everyone. Let's have a good evening. Tukutane hapa tena next week on Thursday. My name is Dr. Agnes Kalu. Good night. You are free to leave at your own pleasure.